All right, we're up to recommendation 13. I think I've made a strong case for the 12 recommendations up to this. This one I insist on. It has to be done this way.
We're going to fold this thing down toward the chest, not up near the ear. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest where it belongs. All right, so we're going to put it on with the slit facing the catheter, and we're going to offset it just a small amount, maybe about 10 degrees. We have the catheter. All right, we're going to do the skin prep. Okay, so we're going to take off the rest of it. Okay. Thank you.
Here's the deal on this. Gravity is the inexorable attraction of the heavenly bodies for one another. If you put a catheter in the middle of the neck or the upper neck and direct it upwards, gravity is going to grab the tail and pull it toward the floor, and when it does, it's going to disrupt that dressing. The nurses in ICU are magical with that bacteria-laden roll of tape in their pocket, and they cinch it down, but it doesn't matter. Gravity wins every time. In the patient I just showed, the tails are coming out the bottom of the dressing, not the top. Gravity's working with you, not against you. It has to be done this way if you think a dressing is important. Moving on to tip location. We covered it earlier, so I'm going to spare you that. All right. What is by far the worst every hospital I go to, what is the worst catheter? Not the worst site, the groin is the worst site, but which catheter has the worst infection record? Hemodialysis catheter, my man. Yes, and this is Mackey's work, and shows basically it's twice the acute central venous catheter, right? So we want the dressings on the chest. Here's a patient of mine, needed an acute HD catheter, 70-year-old guy in the unit, multiple organ system failure, respiratory failure, DIC, short neck, beard, ventilator. His INR was 4. So I have 16 recommendations. The ones in green I use. So we didn't put in his axillary vein. It's a dialysis catheter. He was an AFib. I couldn't use tip location, certainly not intraosseous, and we didn't put it femoral. I want you to pay attention to the steps. I'm working with a resident. I'm coming from the side. Yes, sir.
I was just going to ask, why do you think the HD catheters have the highest? I don't want to say it's because the people that put them in do it wrong and everyone else does it better. Is it the access? Is it the patient accessibility?
There's a whole bunch of reasons for it. One of them is like this catheter here. This is lipstick on a pig, as far as I'm concerned. This can't be put in the way it's put in like this, and it's folded down so it doesn't wind up in your auditory canal. No dressing with this catheter has ever stayed intact. So it's almost like you're defeated by the equipment. They're heavy catheters. The patients are sick.
Rotate that down. I feel like I wouldn't be able to do it.
No. So stick with. Hey, why don't I show you the next thing?
No.
So
that particular catheter, I don't see how I would do.
No. It's my humble opinion. It's lipstick on a pig, right?
It's too short already.
Okay. What's that?
It's too short.
Well, from the right side, the length is not the issue. The length is not the issue. It's that, anyway. So we're putting in a dialysis catheter. Pay attention to the steps. I'm working with a resident. He's doing some, I'm doing some. It's a sick patient. We're coming from the side of the bed, low in the neck, micropuncture technology, no incision, rotating it down, dressing adhesive, all the cool things. Look at the probe. Hit the center of the probe, Christopher. Hit the center of the probe. I'll tell you when to look at the screen. You look at the probe. Disconnect. Pinch it. Slowly. The nitinol wire. Okay. Micropuncture wire. We're going to sink that. 5 French introducer. I do not want to cut the skin of this man with an INR of 3.9. 4. Okay, now because it's been dilated once, we should be able to get this appropriate. Put a little traction on the wire. Okay. Okay, that's 20, I think. So teaching point is, in a patient like this with a short neck, on a ventilator with an endotracheal tube, we do not want a dressing up near the mandible, the hairline, or the ear. We want it down on the chest. Nurse, where do you want the dressing this patient, on the neck or on the chest?
Chest.
Why? Because it lies better and you can provide proper care and maintenance?
Yeah.
Did I put words in your mouth?
Yep.
Okay, all right. And the dressing is going to have a good chance to stay on for the 7 days. Good.
Sorry, you're okay, sir.
You're okay.
It's almost over.
Relax. You're all right.
Okay, and I can feel the dressing going on. Very nice, very in sticky position. So we're going to retract all this. Good. So my question here is that what dialysis catheters look like? So why not? Why not? Knowledge gap. The equipment is bad, no doubt. We need better equipment, but there's a certain, we have to get, it's a human, somebody's loved one, it's somebody's relative,